Hello, it's Dmitry again. Today we'll be returning back to the Mehlman Medical Internal Medicine PDF, talking today about the chapter again regarding the renal system. We did a part 1 video earlier today. We're going to wrap up the section with a part 2. We're on page 92 right now, and we'll wrap up on page 102. So really it shouldn't be that crazy of a video. I think it might be about an hour, I would assume. So, let's get into it. Let me rephrase that. It's 10 pages. It might be, we'll have to see. Let's phrase it like that. I think it might be a little bit longer than an hour, I suspect. But we'll see. We'll see how it goes. So it's hard to say. I might get 10 pages in an hour. I might get 6 pages in an hour. Who knows? You'll know when the video is uploaded, and you'll see what the timestamp is for the final, for what it is at the end. Okay. Cystic kidneys. ADPKD, autosomal dominant polycystic kidney disease, chromosome 16. The answer on USMLE if the disease starts as an adult, i.e. between 30s and 40s. Cysts are technically present early in life, but only become clinical as an adult, that is to say, elevated blood pressure and elevated RFTs, which I think is renal function test, if I'm not mistaken. Let me just confirm that. Renal function test. Yeah, renal function test. You always want to make sure that you know what you're talking about in theory, right? Now, yeah, that's the point. So really, in reality, you have these cysts starting popping up way earlier in life, but it doesn't become clinically relevant until later on, like your 30s and 40s. So it's not exactly like it comes out of nowhere. It just doesn't present itself clinically until that age of your life. These patients have elevated blood pressure due to the increase in the RAS system, the RAAS, the renin-angiotensin-aldosterone system, compression of the microvasculature of kidney due to the enlarging cysts. This can cause saccular berry aneurysms of the circle of Willis, risk of subarachnoid hemorrhage. So it's just so it's just something you will see potentially when you have somebody who has ADPKD. High yield point is that the serial blood pressure checks are correct over the circle of Willis MR angiogram screening. Latter is wrong answer on USMLE. MR angiogram screening of the circle of Willis is only done when there is a positive family history of SAH or saccular aneurysms. So NBME gives you easy vignette of ADPKD, and then the answer is just polycystin as a protein that's messed up. Sounds obvious, but it's asked, so I'm mentioning it. Cystic kidneys are part of the ciliopathies, which is an obscure term that refers to conditions where the cilia are abnormal. Polycystin is a protein required for cilia function on renal epithelium. Most common extrarenal location for cysts is the liver, 85% by age 30. ARPKD, or autosomal recessive polycystic kidney disease, chromosome 6. And before we were talking about the dominant would be 16. So 16 for the dominant form, and chromosome 6 for the recessive form. It might not be in the exam, but I just want to see that, I guess. The answer in USMLE for cystic kidneys in pediatrics would be the recessive form. Can be associated with hepatic fibrosis. So that's another thing to be aware of, is that in the case of the recessive type of polycystic kidney disease, you're going to see it in a child onset, pediatric onset, when the dominant form is going to have an adult 30s, 40s onset. Again, another thing is that you might associate the dominant form with serial blood pressure. Well, you might associate with berry aneurysms, but the recessive type, which is again in kids, might be associated with hepatic fibrosis. So there's these associated issues that are different. Miscellaneous. Just be aware that renal cysts can occasionally develop in other conditions, such as chronic dialysis patients. Conditions such as medullary sponge kidney are garbage for USMLE, waste of time. Okay. High-yield anatomic abnormalities. Posterior urethral valves, PUV. Most common genitourinary abnormality in neonatal males. Urethra has abnormal presence of valves at the posterior prostatic urethra, preventing the outflow of urine. USMLE will give questions of varying severity. Most severe is in utero oligohydramnios. Can present at 12-hour old neonate who hasn't yet urinated plus has suprapubic mass, i.e. full bladder. Can also present at 6-week-old boy who has full bladder, i.e. possibly slower accumulation due to the only partially obstructed outflow. Obstructed outflow increases the risk for UTIs, cystitis, and pyelonephritis. Apart from knowing this diagnosis, highest yield point is that we do ultrasound followed by avoiding cystourethrogram to diagnose. NBME questions might already mention negative ultrasound in the vignette or might omit it altogether, where they just select voiding cystourethrogram. Okay. What about, so this is all, what is this? This is all anatomic abnormalities. Okay, what is this now? Vesicouretal reflux. Congenital abnormality in which the urine from the bladder can go back up into the ureter toward the kidney. Well, that doesn't sound fun. This significantly increases the risk for recurrent acute pyelonephritis, chronic pyelonephritis, as I discussed below. Can it also occur in pregnancy due to two reasons. One, larger uterus in the third trimester can compress the ureters, and then two, progesterone decreases ureteral peristalsis. This is why pregnant women can get pyelonephritis, and also why we always treat asymptomatic bacteriuria in pregnancy, whereas we don't treat it if the woman is not pregnant. Ureteral atresia. A bit of a weird one, but not me being fancy, it's on NBME. Failure of the canalization of the proximal ureter will be the answer if they tell you the renal collecting duct system is dilated, but the ureters are not dilated. Sounds obvious, but I see students get this wrong a lot. You need to simply know that the kidneys go to the ureters, which go to the bladder, which goes to the urethra, and if we have a congenital obstruction at any point, then that could be referred to as a failure of canalization. And therefore, what comes before it, farther up the chain, of course, might be, have some sort of pathology, like, for example, dilation. A congenital ureteral obstruction is an answer on the NBMEs for chronic pyelonephritis causing tubular atrophy, once again discussed below. Genitourinary infection related stuff. For all the STD and STI related stuff, I cover that in the Repro OBGYN section. I'm keeping this small table more limited to the kidney and bladder stuff. Acute pyelonephritis. Infection of the kidney. Pyelo means kidney. Now, 9 out of 10 questions will mention fever plus costovertebral angle CVA tenderness, which is pain with percussion of the flank. Granular cast can be seen. Do not confuse this with acute tubular necrosis. General granular cast can sometimes be seen in pyelonephritis and dehydration. It's on one of these two CK-IM forms where students say, wait, but they say granular cast. How is that not acute tubular necrosis? And the major risk factors are vesicouretal reflux, especially in pregnancy, and posterior urethral valves. Most common organism is E. coli. Other organisms like Klebsiella serratia and Proteus cause struvite stones. Neutrophilic infiltration shows up as lots of purple or blue basophilic cells on histology. USMLE likes this image. So that's the neutrophilic infiltration in the case of acute pyelonephritis. What about the chronic, I would assume, is what they're going to talk about. No, we still have more acute pyelonephritis stuff. So acute pyelonephritis continued. For above image, you might say, Mike, I feel weird. I don't know what I'm looking at. The blue cells are neutrophils infiltrating the kidney in acute pyelonephritis. The USMLE will show you images basically identical to this one for a variety of infections, that is to say, prostatitis, where the bigger picture concept is, oh, that's acute inflammation. These purple cells are neutrophils. That's what the USMLE wants you to know. For instance, a nearly identical image of prostate histo in an old dude with prostate pain and fever, you know immediately it's prostatitis. It's to my observation, bacteria can be few in the urine in acute pyelonephritis. This confuses some students, but it's typically what I see on NBME forms. If the infection is further down, i.e. UTI in the urethra, the bacteria are more copious. Treatment for pyelonephritis is ciprofloxacin or ceftriaxone. USMLE is known to ask these. Persistent fever despite antibiotics treatment. what you do is a do CT to look for the paranephric abscess. For example, old dude plus high creatinine caused by post-renal from BPH plus treated for pyelonephritis now gets sore ankle. Now you go for was created with a Cipro caused by causes tendinopathy. 2CK form has ceftriaxone as an answer in pyelonephritis question where Cipro is not listed. But Cipro is a classic treatment. It is also to my observation that the ceftriaxone is a high-yield drug on 2CK for community-acquired general sepsis or general complicated/severe infections. That is to say, it is hard-hitting and covers a wide array of community organisms, the Cipro. So the ceftriaxone is a pretty broad array, ceftriaxone. There is one 2CK question where they mention pyelonephritis is treated with AMP plus gentamicin, so ampicillin plus gentamicin in the stem, but I've never seen this assessed as an answer you need to choose. I've only seen ciprofloxacin or ceftriaxone as an NBME answer for pyelonephritis. Now we're talking about the chronic pyelonephritis. So chronic pyelonephritis. Due to acute pyelonephritis. Okay. Almost always pediatric, where they give a 4-year-old who has a small shrunken kidney with tubular atrophy and blunting and scarring of the renal calyces. So here's a kidney superior to show loss of architecture plus scarring. USMLE will show you a kidney that looks similar to the above in a child with recurrent UTIs, and then the answer is just tubular atrophy for what is most likely to be seen on a microscopic examination. Another question shows the same image, and the answer is congenital ureteral obstruction as the cause. Thyroidization of the kidney is a buzzy phrase that has been applied to chronic pyelonephritis over the years, but USMLE doesn't so much care about this. What they really care is the tubular atrophy and scarring, loss of architecture of the calyces. Chronic pyelonephritis does not present with cellular infiltration the way that acute pyelonephritis does. It refers to the kidney being destroyed or shrunken from repeated prior infections. So think about these long-term effects for the case of chronic pyelonephritis rather than these acute presentation. Cystitis. Suprapubic tenderness in the female. Patients need not to have fever. E. coli, most common cause. High yield for USMLE. Fimbriae and pilus proteins facilitate E. coli's attachment to urothelium. We'll have bacteria and white blood cells in the urine, i.e. bacteriuria and plus pyuria. Urinary nitrites and leukocyte esterase can be positive. These just reflect bacterial infections. Some students get pedantic about which organisms result in which combination of positive or negative findings here, but that's low yield for USMLE. Can be caused by suprapubic catheters on 2CK, internal medicine, and surgery. Nitrofurantoin is high-yield drug to treat cystitis on USMLE. Chronic interstitial cystitis, not an infection. This is greater than 6 weeks of suprapubic tenderness plus dysuria, pain with urination that is unexplained, where laboratory and urinary findings are negative. They can mention anterior vaginal wall pain, bladder is anterior to vagina. USMLE wants you to know you don't treat. Steroids are the wrong answer, okay? Treatment is standard placating placebo nonsense such as education, self-care, and physiotherapy. That's for chronic interstitial cystitis. It's not an infection. What about general UTI? General UTI, classically E. coli infection of the urethra, common in women due to shorter urethras. As mentioned above, for cystitis, Fimbriae and pilus proteins facilitate E. coli's attachment to the urothelium. Inoculation of the urethra following sexual activity is most common mechanism, can be caused by catheters. You need to know dysuria plus history of catheter equals UTI. Tangentially, this also is high yield for general sepsis, where they mention a history of IV line/catheter. USMLE wants you to be able to say, got it, that's the cause. Trimethoprim and trimethoprim sulfamethoxazole, TMP-SMX, aka Bactrim, or nitrofurantoin are standard treatments for UTI. For prevention, post-coital voiding confers decreased risk of recurrence. Okay. I'm reading from before. It says inoculation of the urethra following sexual activity is most common mechanism. I would assume Okay, and what does it say here? For prevention, postcoital voiding confers decreased risk of recurrence. Okay. If postcoital voiding does not work, postcoital nitrofurantoin therapy is answer on 2-CK-NBME form. If postcoital, if for people who don't know what coital is, coital refers to sexual activity. Okay. If postcoital nitrofurantoin therapy does not work, daily Bactrim prophylaxis is the answer. Sounds absurdly wrong, like a bad idea, but it's an answer a couple times on 2CK assessments. There's also a question where they say a girl was treated successfully in the past with Bactrim for a UTI plus, ask how to prevent recurrent UTIs, and they jump straight to saying daily Bactrim prophylaxis, which is I guess the answer, which is kind of an interest. To be fair, admittedly, kind of a weird answer. If the patient is treated for UTI and dysuria persists, the next best step is testing for chlamydia and gonorrhea, which are actual STDs, right? Anywho, things you can avoid by not having sex, you know. High-yield bladder incontinences. Well, if you're getting a catheter, not exactly the same situation, of course, but you know what I'm saying. High-yield bladder incontinences. Stress. The answer for loss of urine with increased intra-abdominal pressure from laughing, sneezing, and coughing. And also now I realize that I just thought about the nature of it. Okay, so basically the person's getting infected because of the sexual activity that's going on, and there's an infection that's going to colonize their urinary tract, but you can minimize likelihood by urination. They say voiding, but urination afterwards, because that'll minimize any sort of bacteria that might have accumulated in that tract as a consequence of the pre-existing activity that was going on. I'm trying to be very nondescript with you. I think you understand what I'm talking about, right? Okay, infection happens. Where's it go? The urethra. The urethra, if you have voiding afterwards, it minimizes the likelihood that it's going to travel up the urethra. If that happens afterwards, that's what they're trying to get at. Stress. So high-yield bladder inconsistencies. Stress. The answer for loss of urine with increased intra-abdominal pressure from laughing, sneezing, and coughing. Stereotypical risk factor is grand multiparity, i.e. history of many childbirths leading to weakened pelvic floor muscles. I'd say only 50% of questions will mention the history of pregnancy. The other 50% are idiopathic, although they might still mention how old they are, to be fair. Buzzy vignette descriptors and answer choices are downward mobility of the vesico-urethral junction and urethral hypermobility and urethral atrophy with loss of urethrovesical angle. The treatment is pelvic floor Kegel exercises. These notably strengthen the levator ani, pubococcygeus, and external urethral sphincter. USMLE is known to ask which muscle is not strengthened by Kegel exercises, which sounds obscure since any muscle could theoretically be the answer. Well, the deltoid isn't strengthened, but a favorite answer here is the internal urethral sphincter, which makes sense because it's not a muscle that's within your control. It's moderated or mediated by a autonomic effect. It's not mediated by your own intentional actions. The way you know this is because this is the answer because the internal sphincter is under sympathetic involuntary autonomic control, as I just said, which means it's impossible for it to strengthen it via a voluntary, i.e. somatic exercise. Basically, in theory, functionally in practice, that's true. Right. I mean, of course, in theory, there's ways for you to induce certain kinds of reactions in your autonomic system, obviously. Like, to give an example, you can cause yourself to have dilation of the eyes by introducing cocaine, right? You can do all sorts of things that can mess with your autonomic system, but it's not the same way. It's not like a direct effect. You have to mediate it through an involuntary system. USMLE doesn't expect you to be an obstetrician. The bigger picture concept is that simply knowing the internal sphincter control is involuntary. It is external sphincter that is the voluntary or somatic muscle. Do not give medications for stress incontinence on USMLE. If Kegel exercises fail, patients can get a mid-urethral sling, low yield, asked once. And apparently they also have a machine called M-Cella now, apparently, that you can use to deal with that if the person in question has urinary incontinence as well. But I suspect that will not be on the USMLE step 2. I don't think it'll be on the Comlex 2, so don't worry about that either, for as far as exams are concerned. Urge. The answer on USMLE for patient who has an urge, NBME will literally say that the word, I've seen students get the question wrong, to void 6 to 12 times daily unrelated to sneezing, coughing, laughing, etc., otherwise stress incontinence. Ultra high yield for multiple sclerosis. I've had students ask whether multiple sclerosis is urge or overflow. It shows up repeatedly on NBME as urge. I've never seen it associated with overflow, so it's urge for MS. I'd say 1/3 of urge incontinence vignettes on NBME forms are multiple sclerosis. Other vignettes will be perimenopausal women or idiopathic in old women. Mechanism is detrusor hyperactivity or detrusor instability. Vignette can mention woman has an urge to void when stepping out of her car or when sticking her key in the car front door of her house. Sounds weird, but these are important questions to ask when attempting to diagnose urge incontinence. UTIs can present similarly to urge incontinence. Some students have asked, well, isn't it because UTIs are the cause of urge incontinence? Not really. It just happens to be that UTIs can sometimes cause transient urinary urgency. So for example, if they have give a question where they say the patient had a history of urinary catheter plus now has dysuria and urinary urgency, the answer should be urinary tract infection. On NBME, detrusor hyperactivity is the wrong answer. Treatment is oxybutynin, muscarinic receptor antagonist. This decreases the activity of the detrusor muscle of the bladder. Some students get hysterical about maribigron, beta-3 agonist, but I've never seen NBME forms assess this. But remember, there's an association between urge incontinence and MS, multiple sclerosis. So what about the overflow incontinence? So overflow incontinence will be due to either BPH, which is the benign prostatic hyperplasia, or diabetes and USMLE. We will have an elevated or increased post-void volume. Normal is less than 50 milliliters on USMLE for overflow. They'll give you a 300 to 400 milliliter as post-void volume. As I talked about earlier for BPH, they will give old dude plus high creatinine, post-renal azotemia. Next step is insertion of the catheter to relieve the obstruction. If they don't have this listed, measurement of post-void volume can be an answer. We then treat the BPH with finasteride, 5-alpha reductase inhibitor, or an alpha-1 blocker, tamsulosin or terazosin. For diabetes, the mechanism is neuropathy to the bladder causing neurogenic bladder or hypotonic bladder or hypocontractile bladder / detrusor muscle. For neurogenic bladder causing overflow incontinence plus increased post-void volume, remember that the USMLE is first obsessed with measure post-void volume and insertion of catheter if they are listed. They will not force you to choose between the two, but they like these answers prior to giving medications. Okay, so before you medications, go for something like measure post-void volume or insert catheter. Give bethanechol, muscarinic receptor agonist. This stimulates the detrusor muscle. Make sure you don't confuse oxybutynin and bethanechol is pass level for USMLE. So just know that there's a difference between the two. We're talking about bethanechol here for overflow incontinence. We use oxybutynin, which is a muscarinic receptor antagonist, for decreasing the activity of the detrusor muscle for urge incontinence. So it's a different situation. So urge incontinence, oxybutynin to reduce the activity of the detrusor muscle. For overflow incontinence, we're using bethanechol to increase the activity of the detrusor muscle. Normal pressure hydrocephalus. This is a little bit of a detour. Normal, I don't even know how, well, let's talk about it. Normal pressure hydrocephalus. Patient who has a wet, wobbly, wacky presentation, i.e. urinary incontinence, ataxia, cognitive changes, plus or minus Parkinsonism, that is to say, short steppage gait, caused by failure of the reabsorption of the CSF by the arachnoid granulations, results in impingement of the zona radiata and failure to inhibit the voiding reflex, answer on NBME, enlargement of the lateral ventricles on the head CT. So it's only vaguely related to the renal system because it has a failure to inhibit the voiding reflex. What about AIDS complex dementia? Probably similar thing, vaguely related. Presents similar to NPH, the hydrocephalus we're talking about before, i.e., wet, wobbly, wacky in AIDS patient, which is to say, they probably have similar difficulties in inhibiting their voiding reflex. Okay, where are we now? We're going strong. I want to take a brief break and come back to you. We're 25 minutes plus some seconds in. And we have a few pages in. We have like 6 pages left. Okay, yeah, that's fine. Okay, let us get back into it. Urinary retention diagnoses. Bladder neck dyssynergia. Lack of coordination between the bladder sphincters and detrusor muscle. High yield cause is spinal cord injury, which can cause either inability to void or urinary incontinence. Multiple sclerosis is another theoretical cause, which is where the overflow incontinence as a result of MS has been asked by students. But once again, I've only seen urge incontinence for MS on MBME exams. Q-bank and MBMEs are not the same thing. Bladder outflow obstruction. Acute urethral obstruction due to the acute urethral obstruction is due to catheter removal is high yield on 2CK forms. They'll say patient has anuria, that is to say no urinary output at all following removal of a catheter. Acute urethral obstruction or bladder outflow obstruction is the answer. Treatment for NBME is reinsertion of the urinary catheter. Okay. Cauda equina syndrome will present as a leg pain plus a urinary retention on USMLE. Can be idiopathic from the disc herniation or other trauma. Metastases is high yield, i.e. random guy over the age of 50 or female with a high history of mastectomy 5 years ago. Saddle anesthesia is an overrated detail and doesn't show up in the vast majority of MBME questions. Well, that's not fun, as per my observation. So they might tell you the other stuff, talking about disc herniation, leg pain, urinary retention, but saddle anesthesia might be too on the nose. So cauda equina is a collection of nerves at the end of the spinal cord. Impingement on these nerves is what causes the syndrome. I cover this stuff in more detail in my high-yield neuroanatomy PDF. What about high-yield genitourinary injuries? Urethral injury. Always present with blood at the urethral meatus. 3 ways this presents on USMLE. Blood at urethral meatus plus saddle injury. Dude falls unbalanced beam. 2. Blood on the urethral meatus plus pelvic fracture / instability. 3. Blood at urethral meatus plus prostate not palpable. The next best step is retrograde urethrogram. Bladder injury. Answer on USMLE for blunt force trauma to abdomen plus exquisite suprapubic tenderness plus catheter insertion yields 10 to 30 milliliters of dark bloody fluid. Next best step is retrograde cystourethrogram. Do not confuse with voiding cystourethrogram, which is for posterior urethral valves. Ureteral injury. Just be aware this is USMLE's favorite injury for any surgery done in the gynecologic area. Diagnosis is with retrograde pilogram or CT urogram. Although I haven't seen the USMLE care, any ureter injury question I've seen just is ureter as the answer. What about renal injury? Exceedingly high yield on 2CK will present as a bruising or pain over the flank following an accident. Blood in urine is highly sensitive, meaning if it's not there, we can rule it out. First step in diagnosis, is there any gross blood in the urine? If yes, do a CT of the abdomen with contrast to diagnose. It sounds wrong since we're worried about kidney injuries, so students say, why would we use contrast? But it's what USMLE wants. Ultrasound is the wrong answer. So go for contrast CT. Okay. If the patient does not have a gross blood in the urine, next best step is urinalysis looking for microscopic blood. If present, the answer should be CT of the abdomen with contrast. If negative, no further diagnostic studies are indicated. Renal cell carcinoma. Urothelial malignancies, aka clear cell carcinoma. This is the most common variant of renal cell carcinoma. Classic question: is a smoker over the age of 50 with red urine and painful flank mass? Question need not mention smoking, but it is the biggest risk factor. USMLE likes the histo for this, which is where you will show you large clear cells, as you can see here. Can cause polycythemia due to the increase in erythropoietin and hypercalcemia due to the PTH, the parathyroid hormone related protein secretion. Correct. Same as squamous cell carcinoma of the lung. Oh, interesting. Okay, yeah. So remember that PTH-RP is not the same thing as PTH. It will not show high PTH levels, it will show low PTH levels, but it has the same effect. So you will have the effects of PTH being high, hyperparathyroidism, but you will have low PTH, which is weird. But apparently that's also the case of renal cell carcinoma, as it is true for squamous cell carcinoma of the lung. So for example, let's go back into it. For example, they say 55-year-old male plus red urine plus polycythemia plus hypercalcemia plus show you above image. They'll ask you for the source of the malignancy. The answer should be kidney, not lung. Squamous cell carcinoma of the lung won't cause hematuria, nor does it metastasize to the kidney. What about Wilms tumor? Wilms tumor, nephroblastoma, they answer for painless flank mass in a kid aged between 2 and 4 years. It does not present in newborns. If they give you a 12-year-old male, for instance, with a midline mass, that is posterior urethral valves causing a full bladder, let alone the fact that they say midline, not flank. I've seen tons of students select Wilms for this, and I'm like, is the kidney in your midline? If they give you, well, it shouldn't be, right? If they give you a kid 2 to 4 years of age with a midline mass, that is neuroblastoma. They say neuroblastoma. I mean nephroblastoma. That must be a mischaracterization. They mean nephroblastoma. For whatever magical reason, you need to know Wilms tumor is sometimes caused by mutations on chromosome 11. They ask this factoid in 2CK as well. There are various Wilms tumor syndromes you need to be aware of. I'm going to go confirm, because they said nephroblastoma is part of that answer, but they say neuroblastoma. I'm going to say, I think it's Wilms. It's obviously, I mean, it's almost certainly nephroblastoma, but I might be wrong. Nope, it says nephroblastoma. And you can see this big mass growing out of the kidney, basically. Interesting. And it kind of, I guess, expanding. So what are the two different kinds of Wilms tumors? Let's talk about Wilms tumor syndromes. Beckwith-Wheatman syndrome, Wilms tumor plus macrosomia, big baby greater than 4,000 grams, plus hemihypertrophy, half of the body is bigger than the other, plus macroglossia, plus umbilical, plus hypoglycemia. Hard 2CK question gives newborn with macrosomia, plus hemihypertrophy, plus macroglossia, plus umbilical. They don't mention a Wilms tumor. Makes sense, since we said we won't see it in newborns. They ask for what else could be seen in this patient. The answer should be hypoglycemia. I say hard question because Wilms tumor plays no role in the vignette. Not directly. You just need to know that's Beckwith-Wheatman syndrome, and therefore we'll have that as well. What about Wagner syndrome, WAGR syndrome, Wilms tumor, anidria, iris abnormalities, genital urinary anomalies, and retardation? Usually an easy question where they mention aniridia straight up in the vignette, and then you just say Wilms tumor for what the kid can go on to develop. And also the third type of Wilms tumor syndrome is Dennis-Drash syndrome. Ambiguous genitalia plus Wilms tumor. What are some other kinds of malignancies? Well, we have collecting duct carcinoma, rare as flip, heck. 0 to 3% of renal malignancies, but shows up on NBME. Here's a picture. Offline NBME question shows some pic of a kidney split open like this, and then the answer is just nathylamine, most mothballs, as the causative agent. Ugh, okay. Well, that doesn't sound fun. You put some mothballs in your clothes, mothballs in your closet, I guess, and then you get this stuff. Everything. Hey, at the end of the day, though, everything gives you cancer. So, sometimes you just got to pick your battles. You have to exercise wisdom, but don't overdo it. Be careful. Transitional cell carcinoma of the bladder. Most common bladder cancer. Classic vignette is hematuria in smoker without a painful flank mass or polycythemia/hypercalcemia, otherwise renal cell carcinoma. USMLE wants you to know that smoking is the most common risk factor, but aniline dyes, industrial clothing dyes, and nathylamine are important causes. 2CK surgery question gives stage 0 bladder cancer vignette. Answer is just endoscopic resection. I've seen BCG vaccine as correct answer on NBME. I've only seen it as a distractor. For whatever reason, some studies in the past have suggested that intracystic installation of the TB vaccine can help with bladder cancer, but this is wrong on USMLE. You can have papillary structure on histo. Squamous cell carcinoma of the bladder. It can be caused by schistosoma hematobium, a trematode or fluke, which is a type of helminth. The schistosoma hematobium lays its eggs in the bladder wall and cystic veins draining the bladder. Vignette will be a young guy who has red urine for months after returning from Africa where he went swimming in a lake. Answer is just schistosomiasis. Or they'll ask what he's at risk for developing, and it would be squamous cell carcinoma. Doesn't sound fun. We're on page 100 now, by the way. We have a few pages left. We have 100, 101, 102, I believe. Obscure miscellaneous conditions. Bartter syndrome. Okay, I'm thinking, where are we going to get into the drug stuff? We're soon enough. Bartter syndrome, disease that presents as though patient is on a loop diuretic, for whatever magical reason is associated with juxtaglomerular cell hyperplasia. Okay. Gittleman syndrome, disease that presents through when a patient is on a thiazide diuretic. Gittleman syndrome. Oh, as though this is ridiculous. So Bartter syndrome is like if you're on a loop diuretic. Gittleman syndrome is like if you were on a thiazide diuretic. Make sense? Maybe you can look up into how that works exactly, but not for the course of this video. I'm not going to explain it to you. Hypertense summary of drug. Probably because I can't give you a good enough explanation about it myself. To be honest with you, you might not need to know it either, but whatever. Anyway, hyperterse summary of drugs causing high-yield renal conditions. Discussed all this stuff earlier, but students confuse this stuff a lot, so the summary is warranted. Acute tubular necrosis, ATN. What causes it? Aminoglycosides like gentamicin, tobramycin, amikacin, cisplatin. Now, there's other causes for it too, but those are the drug-related causes. What about interstitial nephritis? NSAIDs, beta-lactams, and cephalosporins. What about membranous glomerular nephropathy? Dapsone, gold salts, and sulfonamides. I'm like, we're so close to finishing this up. Diuretics / renal-related drugs. So we have Bauman's capsule, proximal tubule, we have mannitol, acetazolamide, expired tetracyclines. We have Lupihenlane with furosemide and anthraquinic acid. Those are the loop diuretics. And they act really on the thick ascending limb. Thick ascending limb, I think they act on, yes. Yeah, then you have the distal tubule where the HCTZ thiazide diuretics work. I think there's another thiazide diuretic as well. Chlorthalidone, I believe it is. And then the final part is a collecting duct. That's where cortical medullary says amiloride, tramtarine, spironolactone. Okay, for these cortical areas, it is amiloride, tramtarine, spironolactone, and a pleuronone. And then the medullary area, they say tolvaptan, conivaptan, demeclocycline, and lithium. Now, those ones we mentioned in the red, the demeclocycline, lithium, and expired tetracyclines, I guess those are like undesirable impacts, maybe? I'm not quite sure. We'll have to look into it. Mannitol, osmotic diuretic that increases osmolality of urine, thereby retaining free water within the PCT and descending limb of the loop of Henle. It can be used as a treatment for increasing the intracranial pressure after the patient has been intubated plus hyperventilated, decreasing CO2, leading to a decrease in cerebral perfusion. Avoiding the heart failure, transient increase in serum osmolality prior to renal excretion leads to an increase in retention of free water within the vascular space, leading to transient increase in preload on the heart. What about acetazolamide? Carbonic anhydrase inhibitor, enzyme that enables the bicarb to, that's bicarbonic acid to bicarb plus hydrogen action, that it acts within the tubular cells of the PCT. Classic use is the altitude sickness, which causes a decrease in reabsorption of the bicarb in the PCT. This results in an elevation in urinary pH and volume, plus decrease in serum pH and volume. In altitude sickness, patients hyperventilate, decreasing CO2 and increasing their pH to take in more oxygen, but it takes a minimum of 12 to 24 hours for the kidneys to decrease bicarb reabsorption, so acetazolamide forces the decrease in reabsorption by causing metabolic acidosis. Really what's going on is that, I'll explain as the best I can. So your body has a way of trying to absorb, I believe it is bicarb from your urine by pumping out a hydrogen. It turns into carbonic anhydrase, and then it breaks that down into carbon dioxide and water, which is then readily absorbed into the body, and then converted back via carbonic anhydrase back into a carbonic acid, which then is converted into a bicarb and a hydrogen ion. The hydrogen ion is then recycled. This proton is recycled over and over and over again between the luminal space and the cellular space, while the body continues to pump out bicarb and keep it in the body. And this is a way for the body to absorb base for itself. Now, with that being said, if you're in a situation, for example, where you are in a low oxygen environment, so you're breathing more, you're going to be expelling more carbon dioxide than you otherwise would because you have because you have a low oxygen environment, you have increased respirations, right? And I think it's called hyperpnea. And as a consequence of that, you're going to have low CO2. Now, CO2 increases your acid content, therefore it's lowering your pH. So you will have a respiratory alkalosis as a consequence of your low CO2. You have hypocapnia. And so what your body will do in long term will have a metabolic compensation by trying to have a quote-unquote, he could say quote-unquote metabolic acidosis, but really it's just metabolic compensation, which in isolation would have been acidosis, but in reality, it's a compensation mechanism for your already existing respiratory alkalosis. Makes sense? But because the metabolic system is a lot slower to compensate than the respiratory system, if you have a respiratory issue, then you're going to have a accommodation that's going to be kind of slow. Make sense? Anyway, the way acetazolamide works is that it inhibits the carbonic anhydrase, which prevents the reabsorption of both the water and the carbon dioxide. Now, of course, you're thinking, oh, that's great because I'm absorbing less water. If you want to use acetazolamide as a diuretic, it helps you absorb less water, but it also prevents you from absorbing the bicarb, because what's happening is that water and carbon dioxide is absorbed, and then it converts back via carbonic anhydrase again into carbonic acid and then hydrogen ions, which then carbonic acid, which then becomes the bicarb again and the hydrogen ion again. So in a certain sense, the purpose is to absorb bicarb, but it's being used, acetazolamide might be used, if it's being used as a diuretic to prevent water absorption, right? But it can also be used if you want to prevent yourself from getting respiratory alkalosis, if you're going to go into the mountains or something, by taking it in advance to make sure that you have a already up and running metabolic acidosis for compensation. Make sense? Hopefully you did. If you didn't, maybe watch a sketchy video on it. Maybe go look it up yourself. Expired tetracyclines can cause Fanconi syndrome, decrease in ability of the PCT to reabsorb amino acids, glucose, and bicarbon phosphate. Furosemide. Let's talk about furosemide. Okay, this is a little bit more complex. Furosemide, classic loop diuretic that inhibits the apical sodium potassium 2-chloride ATPase symporter on the thick ascending limb. Apical means side of urine. Basolateral means side of blood. Most efficacious diuretic at enabling fluid unloading for pulmonary and peripheral edema. Answer on the USMLE for patient with heart failure who has a decrease in oxygen saturation who refuses to lie supine/back on the gurney because he or she cannot breathe. Question might say chest x-ray or exam shows fluid two-thirds up the lung fields. Okay. Also answer for the first drug to decrease peripheral edema. Application of loops can be confused by students with a ACE inhibitor or angiotensin receptor blocker. For instance, the latter are used first line to increase the ejection fraction in heart failure even if O2 saturations are low. That is to say, a decreased angiotensin II constrictive effect on arterioles causes a decrease in afterload, which causes heart pumps, so the heart pumps easier. But loops are the first line if the vignette specifically emphasizes the shortness of breath and low O2 saturation of the patient as the focus. Loops do not decrease mortality in cardiac patients. They are simply used for fluid unloading for pulmonary and peripheral edema. They can cause ototoxicity like tinnitus and vertigo. High yield point is that they can cause hypokalemia, low potassium. What USMLE loves to do is tell you that a patient is initiated on furosemide, but it is insufficient plus now needs a second diuretic, the answer should be anything that is potassium sparing. That is to say, ENaC inhibitors such as amiloride or triamterene, or aldosterone receptor antagonists such as spironolactone or eplerenone. Loops increase urinary calcium. This is in contrast to thiazides, which decrease urinary calcium, like hydrochlorothiazide or chlorthalidone, right? Ethacrenic acid is another loop diuretic that you can be aware of. It is used in patients with sulfa allergies because furosemide is a sulfa drug, but ethacrenic acid is not. Since furosemide is a sulfa drug and it is also ototoxic. Okay, so anyway, we're on page 101 right now. We wrap up in 102. Let's just try to get through this last portion. Thiazide. Where are we on time? I'm curious. Oh, we're making okay time. It's 52 minutes in. We can probably get this done in just after an hour, maybe. Thiazides. Hydrochlorothiazide, HCTZ, is a high-yield example. Chlorthalidone is a thiazide-like, inhibits the sodium chloride symporter on the apical membrane of the early distal convoluted tubule. Thiazides and dihydropyridine calcium channel blockers are used first line for hypertension in patients without any renal or cardiovascular issues. If the patient has proteinuria, increases in creatinine or renin, or prediabetes or diabetes, ACE inhibitors or ARBs are used first. Used to decrease the recurrence of calcium stones by promoting an increase in reabsorption of the urinary calcium. In turn, they can sometimes cause hypercalcemia. It can be used in heart failure in patients with diabetic nephropathy who are already on ACE inhibitors and beta blockers. Sounds specific, but there's a new 2CK question that has thiazide as the correct over the spironolactone in a diabetic. So thiazide before spironolactone, I guess. Spironolactone can cause hyperkalemia in patients who have worrisome kidney function. Thiazides can cause gout, i.e. contraindicated in gout. Offline NBME 20 wants you to know thiazides can cause galactorrhea, milky white discharge from the nipples, via some obscure mechanism. Literature shows that it accounts for 0.2% of adverse effects of thiazides, but count on NBME to ask it, of course. Okay. Amiloride and triamterene. These are ENaC inhibitors. They block the apical sodium channel in the cortical collecting duct, leading to a decrease in sodium reabsorption, leading to a decrease in water reabsorption. These are potassium sparing, which means they do not decrease serum potassium. This is because by inhibiting the apical ENaC channel, they indirectly inhibit the basolateral sodium potassium ATPase. This leads to a decrease in sodium reabsorption plus a decrease in potassium secretion. The answer in USMLE for a second diuretic given in a patient already on furosemide who needs additional fluid unloading. Be careful, however. I've seen one question where the patient is on furosemide, but the point of the question is he or she needs hypertension control, and the answer is thiazide, not the ENaC inhibitor. You want to select an ENaC inhibitor specifically if the question says, we have a patient who has peripheral/pulmonary edema due to the X cause plus is already on furosemide. What do we do now? The answer should be amiloride or triamterene. What about spironolactone? Spironolactone, aldosterone receptor antagonist, spironolactone and eplerenone. These are aldosterone receptor antagonists. By blocking the aldosterone receptor, it decreases the activity of the basolateral sodium potassium ATPase, which leads to indirect decrease in activity of the apical ENaC, leading to a decrease in sodium reabsorption and decreased water reabsorption, which is why it's a diuretic. Potassium-sparing diuretic, same with the ENaC inhibitors, it is used for fluid unloading in patient who is already on furosemide in whom we worry about dropping their potassium too much. Used in heart failure up the hierarchy of meds, i.e. ACE inhibitors, ARB first line, followed by beta blocker, adding that on as an add-on, followed by spironolactone. But if the patient is a diabetic with poor renal function, don't add spironolactone here. Give a thiazide instead as the new 2CK NBME. Can be for aldosteronoma, Conn syndrome prior to surgery. Can cause gynecomastia, anti-androgenic effect by blocking androgen receptors. Eplerenone has a decreased risk of gynecomastia compared to spironolactone, but USMLE does not care. Resource self-aggrandizement garbage that's been regurgitated at times over the years. Lisinopril, USMLE favorite ACE inhibitor. Prevents conversion of angiotensin 1 into angiotensin 2 because it's an ACE inhibitor, yeah. In the lungs, used for hypertension in patients with prediabetes, diabetes, atherosclerotic disease, or renal disease. I talk about this in my high yield risk factors PDF in more detail. Can cause dry cough. ACE is aka bradykinin, so ACE inhibitors cause decrease in breakdown of bradykinin in the lungs, causing a cough. Can increase serum potassium since the decrease in aldosterone synthesis. Aldosterone normally secretes potassium in the distal kidney. Avoid in hereditary angioedema. Valsartan, angiotensin 2 receptor blocker, or A or B. Use cases are identical on USMLE to ACE inhibitors, i.e., if you see both as an answer choices to a question, they'll usually both be wrong because they're the same. Doesn't cause dry cough the same way that ACE inhibitors do. So they just say lisinopril writ large. Lisinopril, captopril, there's more prils. So I'll give you that as a hint. For valsartan, candesartan, losartan, so these ones, tolvaptan, conivaptan, let's talk about those. ADH receptor antagonists at V2 receptor in the medullary collecting duct, can be used for SIADH, which is going to be the syndrome of inappropriate ADH, I believe it is. Remember, however, that dimeclocycline is also an answer on 2-CK-NBME for SIDH. So dimeclocycline, but also the vaptans as well, can be used for SIDH. So if you're trying to treat SIDH and you don't see a vaptan, look for dimeclocycline. Okay, and that concludes our entire chapter for renal from the Mehlman Medical PDF for internal medicine. So hopefully you found that useful. If you didn't, I don't know what to tell you, but hopefully this was a good use to you. We got it done in under an hour, well, the remaining part of it, I should say. We have a part 1 as well, which you can find on this channel. If you like the videos, like and subscribe and all of that kind of stuff. I hope you have a great rest of your day. Thank you, and good